My dear doctor friends, today I have chosen this topic, LDL, statins and beyond. We all know that LDL is the strongest risk factor for atherosclerotic vascular disease. We also know that statins are the very important drugs in the armamentarium of reducing the lipid burden. But this presentation is about focusing something beyond the LDL and beyond the statins and beyond the LDL lowering effects of statins. That's why I titled this as LDL, statins and beyond. Today's topic of LDL, statins and beyond will have the following components. What are the LDL lowering effects of statins, and to what extent are these effects translated into reducing the atherosclerotic vascular burden? The second aspect is, all of us use statins, but we do not use them at the optimum dose depending on the level of risk of the individual, depending on the level of the lipoproteins. And also, majority of the physicians are not persisting with the required doses of statins for almost a prolonged lifetime period. This is what is called the optimization of statin utilization, which is very much lacking, and we will focus on that. The third important aspect is, not only the LDL, we have other atherogenic particles. The concept of non-HDL or NHDL is essential for all of us to get into and see that not only we reduce the LDL burden, but also reduce the NHDL burden in total. NHDL, of course, is a summation of all the atherogenic proteins, including LDL. So, the fundamental target will be LDL control and the secondary target would be NHDL control. Lastly, in this presentation we will see what are the non-lipid lowering effects of statins, because statins are said to possess pleiotropic effects, and what are they and how they are beneficial for reducing the CVD risk. This is a summary slide developed by the American Diabetic Association summarizing the entire cardiometabolic risk spectrum. CMR or cardiometabolic risk is today's watchword and catchword. Cardiometabolic risk or global diabetes and CVD risk, as you can see in the center, is contributed by several factors. The most important component of cardiometabolic risk is the insulin resistance, which you see on the left hand side. Insulin resistance acts in a three-pronged manner to produce cardiometabolic risk. 1. By increasing the glucose load, hyperglycemia and diabetes. 2. By increasing the blood pressure, hypertension. 3. By dyslipidemia. All these mechanisms are produced due to the onset of insulin resistance. What causes insulin resistance? Overweight and obesity, particularly truncal obesity, visceral obesity, abdominal obesity, whatever you call. That is the basis or root cause of insulin resistance, coupled with genetics and age. Insulin resistance by itself may have a direct effect on the cardiometabolic risk, not only through lipids, BP and glucose. The second important aspect is the dyslipidemia. Abnormal lipid metabolism, as you see on the right hand side, increased LDL, decreased ApoB, decreased HDL, increased ApoB, decreased HDL and increased triglycerides. This is what is called atherogenic dyslipidemia. This by itself contributes directly to metabolic abnormalities and cardiometabolic risk. Of course, this atherogenic lipoproteinemia can be a byproduct of insulin resistance or can be due to adeno mechanism that is occurring in the body. Among the controllable risk factors are smoking and physical inactivity, and of course hypertension per se is an independent risk factor, inflammation and hypercoagulatory state. And lastly, we are left with a chunk of risk factors circled here: the age, race, gender and family history. Age is an important risk factor. As age advances, CV risk increases, CMR increases. Race, Asian Indians, particularly Indians, we are more prone for cardiometabolic risk, and the risk of CVD in Indians or Asian Indians is much higher compared to other countries. Gender, there is a gender protection until the age of menopause in women, but beyond that they catch up with men. When you come to the family history of premature coronary artery disease, particularly in the siblings compared to parents, the sibling family history of premature coronary artery disease is strongly linked to cardiometabolic risk. So, this is the summary information we all know, and if you want to reduce the burden of cardiometabolic risk, it is needless to emphasize that one has to tackle all these components and then address the treatments to tackle each of these independent components. Unless that is done, looking at diabetes alone or looking at hypertension alone or lipids alone is not going to work and reduce the cardiometabolic risk. Around 2 decades ago, we were considering hypertension, dyslipidemia and diabetes as 3 different distinct clinical entities and diseases, and we were addressing our treatments. If we see a patient of diabetes, we were addressing our treatments to diabetes alone, likewise dyslipidemia, likewise hypertension, but we all know that they were the basis or root causes of CVD. That was the previous paradigm. But what is the present paradigm? Today's paradigm is cardiometabolic risk is the central one over which the diabetes, lipids, hypertension and metabolic syndrome all contribute their respective shares, and there is a lot of overlap of diabetes and metabolic syndrome and hypertension, hypertension and dyslipidemia, dyslipidemia and diabetes, dyslipidemia and metabolic syndrome, and various combinations. Basically, dyslipidemia, metabolic syndrome, diabetes, insulin resistance, hypertension, all these together act, and they are not different diseases anymore. They are the different facets of the same atherosclerotic vascular disease or the forerunner, the cardiometabolic risk. Unless and until we take them as one disease, we will be failing in our duty in properly addressing assessment of the risk factors for all these things, and also for tailoring the treatment to meet the needs of all these different entities. For prevention, either primary or secondary, assessing these risk factors and addressing these risk factors is essential. Then only we can reduce the cardiometabolic risk and prevent the onset of future cardiovascular disease. Unfortunately, even today, many of the specialists, many of the super specialists, many of the general physicians, many of the internists, they consider as coronary artery disease as a separate disease, cerebrovascular accidents a separate disease, chronic kidney disease as a separate entity, peripheral arterial disease as a separate entity. But again and again we find that the same cardiometabolic risk factors operate to produce in one individual CAD, another individual stroke, another individual CKD, another individual PAD. So today's paradigm is CKD, stroke, CAD and then PAD are one and the same. They are not different diseases. They are the different manifestations of vascular ill health. They are the different manifestations of endothelial dysfunction. How do we get the vascular health back on the rails and see that these diseases do not develop or be full blown? It is by addressing all the risk factors that we have already listed in the previous slides and try and control the risk factors, those which are controllable, to the best possible extent with the available tools. Then only we can probably reduce the burden of cardiometabolic risk and also the future burden of cardiovascular disease. So remember that this is the new CVD paradigm. This diagram summarizes the CV events versus the cost. There are 3 stages here, as you see, 1, 2 and 3. In the first stage, there are a number of people who have the risk factors or the so-called events there, and the number is so much, but the cost to reduce the risk burden is so small, as you can see in a small blue triangle there surrounding the digit 1. When you go to the second stage, there are people who have progressed to target organ damage and some asymptomatic disease, and the number of people who have such events are less, but the disease burden is more, and to prevent those events, the cost is much higher compared to stage 1. But the third stage is where people who have florid CVD, CKD, CAD and PVD, all sorts of atherosclerotic cardiovascular disease, though the number is small compared to 1, 2 here, the cost of taking care of them and cost of interventions, cost of treatment and cost of managing such patients is enormously high. So this 25% of the events take around 85% of the cost. The remaining 75% of the events in stage 1 and 2, they require a cost of around 20%. Is it wise for us to allow the people to develop the stage 3 disease or the full blown CVD and try and at a great expenditure reduce or try to control their disease, or tackle the problem right at stage 1 with minimal cost? The answer is simple, and all of us have to try and prevent the disease rather than allow the disease to be full blown. This is what is called the cardiometabolic risk approach. Look at the structure of the 2 human bodies here. The one on the right hand side with the android obesity and one on the left hand side with the gynoid obesity. The gynoid obesity means there is a general uniform increase in the subcutaneous fat. The intra-abdominal fat is decreased and it is not increased. Whereas in the android obesity, the intra-abdominal fat is increased and the subcutaneous fat is decreased. So if you have a generalized obesity, you are relatively safe because there is no increase in the triglyceride, normal HDL cholesterol, insulin sensitivity is maintained, glucose intolerance doesn't occur, no inflammatory and thrombotic profile develops, no metabolic syndrome, decreased CVD risk. On the other hand, if we have an obesity with a same BMI of 30 kilograms per meter square, with an android type of obesity, abdominal obesity, truncal obesity, visceral obesity, several types of names are given. This increases the intra-abdominal fat, decreases the subcutaneous fat, there is an altered metabolic profile, hypertriglyceridemia occurs, low HDL levels prevail, insulin resistance is the hallmark, glucose intolerance develops, pro-inflammatory and pro-thrombotic profile is the end result, results in metabolic syndrome, and this increases the cardiometabolic risk and increases the CVD. So remember that a given patient, it is not just the BMI that he has got. Of course, the BMI less than 25 is always safer and better compared to BMI more than 25. But given a higher BMI, the patient doesn't have abdominal obesity, he is safer compared to another person who has an abdominal obesity, who develops the metabolic syndrome pattern and has the CVD. Look at the 3 human figures here. The extreme left figure is the Caucasian, whose intra-abdominal depot of fat is comparatively smaller than to an Indian, but still almost same as the subcutaneous tip of fat. In the central negroid man, the African people, they have fat, but the fat is mostly in the subcutaneous tissue and very little is in the intra-abdominal region or the truncal region. And look at we, the Asians, we have more of the intra-abdominal fat and less of the subcutaneous fat. We now know that the intra-abdominal fat is the culprit, and it is the one which causes metabolic syndrome and all the CMR risk. So compared to Caucasians, we are at a very higher risk of CMR, and the lowest risk is enjoyed by the negroid race, who have the lowest amount of intra-abdominal fat compared to the subcutaneous fat. So it's the distribution of the fat in the whole body that matters than the amount of fat. What are the two important components of lipids in the plasma? The esterified cholesterol and the triglycerides. Esterified cholesterol EC, triglycerides TG. What are the two components in lipids in their outer layer? The outer layer of lipids contains the free cholesterol called FC and the phospholipids designated as PL. What are apoproteins and why are they needed in the lipid molecules? The outer protein coat of lipids is made of apoproteins. These apoproteins make the lipids soluble. As such, the lipids are insoluble particles in the plasma and they cannot travel. So, with the cover of the apoprotein around them, they are made soluble and thus they are helped in transport from one place to another, from the liver to the peripheral organs, from the peripheral organs back to the liver and to the various target organs like adrenals and other places where the cholesterol and lipid molecules are required, and to the fatty deposits for storing the food energy in the form of fatty acids in the adipose tissue, and again bringing back the fatty acids into the system whenever the energy is required to burn the fatty acids. For all these transportations, apoprotein coating is required, and lipids when coated with apoproteins are called lipoproteins or lipoproteins. So, our lipoprotein molecule can be conceptualized as two travelers traveling in a boat. The one fellow red one is the esterified cholesterol and the violet one is the triglyceride. These two are the basic lipids that have to be transported in the plasma. As they cannot swim in the plasma, as they are not soluble in the plasma, they require a boat, and that boat is the apoprotein. The apoprotein is the outer cover. You can see on the right hand side the diagram with the central triglyceride and esterified cholesterol round molecules. The triglycerides are represented with 3 spokes and the single spoke one is the esterified cholesterol. Whereas the outer chain contains phospholipids and non-esterified or free cholesterol without any spokes. And you see bubble like things, these are the apoproteins. Depending on the type of the apoprotein, the lipoprotein will be either an atherogenic lipoprotein or an atheroprotective lipoprotein. We can see in the next slide. Look here on the left hand side, you have the green fellow, the HDL molecule. The HDL molecule has got mostly esterified cholesterol and a small quantity of triglyceride, the violet part. And it has got a boat, the boat represented here as green color, because the HDL molecule is like the atheroprotective molecule and it contains 2 apoproteins, A1 and A2. So, here HDL molecule on the left hand side, and you see on the right hand side the LDL molecule, which is the most atherogenic molecule, and the cholesterol ester there is represented in red color, and the boat also is given a red color, and the apoprotein, the boat is here B100. Unlike the A1 and A2, here the boat is a B boat. If it is a A boat, it is a protective cholesterol that comes out. The apoprotein A boats and apoprotein B boats are the atherogenic cholesterols like LDL, intermediate density lipoprotein, or IDL, or very low density lipoprotein, or VLDL. These are atherogenic in nature and contain apolipoproteins B100 or B48 and or a small protein called LPA or the small a. LDL of course doesn't contain small a and 48, it contains only B100. Look here on the left hand side. Let us assume that the total cholesterol in this particular individual is 200 milligrams. It can be classified into those molecules which are protective and those molecules which are atherogenic. Let us say if the HDL is 50 or if the protective component is 50, 200 minus 50 or 150 milligrams will be the non-HDL or the atherogenic component of the lipid. So, the police force or the protective force is 50 milligrams, the terrorist force or the atherogenic force is 150 milligrams, making up to a total of 200 milligrams here. Let us go to the right hand side. Same diagram, the atherogenic component, the NHDL or non-HDL is broken down again into two components, the LDL or the low density lipoprotein, the highly atherogenic molecule 120 milligrams, and the 30 milligrams of VLDL. VLDL, the surrogate for VLDL is triglyceride, 1/5 of the triglyceride is VLDL. So, if the VLDL is 30, the triglyceride will be 150. So, 30 milligrams of triglyceride originated VLDL and 120 milligrams of LDL together form the NHDL or the non-HDL component or the atherogenic component, and the 50 milligrams of protective component or HDL component is already there. So, this is how we have to understand the lipids as HDL and non-HDL, and among the non-HDL, LDL and the non-LDL component of the atherogenic proteins. We have here on the left hand side triglyceride rich proteins, and these are the VLDL, VLDL remnants and intermediate density lipoproteins. You see, the size of the particle from the VLDL to IDL is reducing. As the density of the lipoprotein increases, they become more compact and the size of the particle becomes smaller. When you move on to the right hand side, we have two other particles called the LDL and the small LDL. LDL itself is a highly atherogenic particle, and if it becomes much more compact and gets converted into the small dense LDL particle, it is the most atherogenic among all the particles. In general, the greater the density, the smaller will be the particle. If the density of the lipoprotein increases, the size decreases. The smaller the particle, the more atherogenic it will be. So to say, VLDL is least atherogenic and large in its size and less dense, whereas LDL and HDL are more dense, small or smaller in their size compared to VLDL, and they are more atherogenic. The smaller the particle, the greater is the danger. HDL has got three subtypes: HDL1, HDL2 and HDL3. HDL1 and 2 are atheroprotective. They contain apoprotein A1. By virtue of their apoprotein A1, they exhibit their atheroprotective nature. Whereas the particle HDL3 is not containing ApoA1, instead it contains only ApoA2, and this is not atheroprotective. In fact, it is atheroneutral. Intake of alcohol increases HDL, but not the atheroprotective HDL. It increases the HDL3 or the atheroneutral HDL. Let us consider about non-HDL cholesterol or NHDL cholesterol. Total cholesterol, when you subtract the HDL component from that, the one that is left out is the non-HDL cholesterol. And this non-HDL cholesterol, as we have already seen, has got two components, the LDL and the VLDL. The surrogate for the VLDL is the triglyceride divided by 5. So, LDL plus triglyceride divided by 5 is equivalent to NHDL, or NHDL is nothing but total cholesterol minus HDL. NHDL goal, what is the goal of NHDL? It is 30 milligrams above the LDL goal. If the LDL goal is 100, NHDL goal is 130. The LDL goal is 70, the NHDL goal is 100. This 30 is obtained because we know that the normal triglyceride level should be around 150, and 150 divided by 5 is equal to 30. So, the NHDL components are 2 LDL plus the Tg by 5. LDL here, if it is 100, the Tg by 5, if it is 30, then the NHDL will be 130. What is the significance of NHDL? It includes all known atherogenic particles. It correlates very closely with visceral adiposity and abdominal obesity. It is a stronger predictor of CVD than the LDL cholesterol. Let us enumerate the atherogenic and atheroprotective particles. The topmost important particle is the LDL. Next comes the LDL particle number and the size. The greater the number of LDL particles and the smaller the size of the LDL particle, the more is the atherogenicity. Then the ApoB 100 molecules. How many ApoB molecules are present per unit of plasma? The greater the number of ApoB 100, the greater is the atherogenicity. Small dense LDL or the very highly dense particle of LDL, which is called SLDL. It is the most atherogenic of all the lipoproteins. Then comes the intermediate density lipoproteins. These are also atherogenic, but not to the same degree as LDL or SLDL. Triglycerides are a surrogate of VLDL. Triglycerides and VLDL, they are not directly atherogenic, but they give rise to IDL and they give rise to LDL, and most importantly triglycerides and VLDL, they give rise to small LDL, and these are increased, the triglycerides and VLDL are increased in metabolic syndrome, in people with insulin resistance, in people who have abdominal obesity. Lipoprotein A small lipoprotein similar to LDL but contains an additional small protein called little a protein, and this is a highly atherogenic lipoprotein. Majority of the Indians, they have higher levels of lipoprotein A. Anything more than 30 milligrams per deciliter of LPA is abnormal. Then comes the decreasing levels of HDL 1 and 2. They pave the way for atherogenicity because the protective effect of HDL is withdrawn. Then the new particle described as HDL3 or a large HDL3 which contains ApoA2. And is it atherogenic? There is a question mark, and some studies have shown that large HDL3, instead of being atheroneutral or atheroprotective, it could be atherogenic. But relatively the data is sparse, and we need to wait and see for a few more trials to come and report what is the role of this large HDL3 particle. So these are all the atherogenic particles producing atherogenic environment. On the right hand side, we have HDL 1 and 2 subfractions which are atheroprotective, very nature of apoprotein A1, and then the dense HDL small particle which is highly atheroprotective, and the ApoA1 number of molecules by themselves. Now remember, there are certain new factors like the HSCRP, the homocysteine and fibrinogen. Their exact role as causative agents or risk factors is not known. They appear to be more markers of the atherogenicity rather than the cause of atherogenicity. Nonetheless, in high risk patients, it may be necessary to estimate HSCRP, homocysteine and fibrinogen whenever we find cases of aggressive atherosclerosis, particularly in the very young. Risk factor assessment tools like your Framingham risk score or UKPDS risk score or the Diabetic Association, American Diabetic Association risk score, the PHD, these can be very much used for advantage to classify patients and to stratify them into different categories of risk. Nuclear magnetic resonance test is used to identify the LDL particle number and the size. It's a very expensive test, not very widely available, but nonetheless it is probably the best test to document the atherogenicity, that is the number of LDL particles and the size of the LDL particles. The greater the number and the smaller the size, the greater is the atherogenicity. We always do the lipid profile in a fasting state. but all the components of lipid profile are not affected by food. Only the triglycerides are affected by food, except triglycerides. None requires fasting. If our intention is to look at other lipoproteins other than triglycerides, a non-fasting sample will be as good as a fasting sample. Why use the ratio of ApoB to ApoA1? ApoB we know is the representative molecule of all the atherogenic proteins. ApoA1 likewise is the representative of all atheroprotective molecules. So a ratio of ApoB to ApoA1 incorporates both the atherogenic and the atheroprotective molecules. ApoB is the best predictor of CVD, even beyond LDL, even beyond NHDL. ApoA1 is the best marker of the so-called good cholesterol or the HDL cholesterol. Amoris trial, it was the best predictor, best parameter which predicted the coronary vascular events. ApoB by ApoA1 ratio was the best predictor. The largest intra-heart study, which is globally applicable because the patient pool is drawn from 52 countries, it has been very clearly demonstrated that ApoB to ApoA1 ratio is the best predictor of CVD. In fact, it has predicted about 50% of the CVD, and all the other risk factors have accounted for the remaining 50%. The limitation of this particular ratio, ApoB to ApoA1, is these tests are not widely available. But unlike the popular belief, these tests are not very costly. If you ask an estimate of ApoB and ApoA1, it may cost around 400 to 500 rupees. But availability, universal availability is a problem. LDLc is most powerful for predicting cardiometabolic risk. ApoB 100 is the lipoprotein coat of the LDL, and it is much better predictor of the CMR than LDL alone. LDL and non-HDL cholesterol together are nearly as good as measuring ApoB. ApoB 100 measurement is costly and not easily available everywhere. So if you measure the LDL and quantify the NHDL, together they will tell you about the atherogenicity of the plasma. LDL is a more harmful protein in patients with insulin resistance or diabetes than in those without insulin resistance or diabetes. Very understandable. Same level of LDL, given the same level, there is no gender difference in the cardiometabolic risk. LDL is not a strong predictor in the elderly, particularly around 70 and above years. LDL loses its predictive power as a risk factor for cardiometabolic risk. Lowering LDL lowers the CVD, either in the primary prevention or in the secondary prevention. Triglycerides are but weak predictors of CVD. Once they are adjusted for LDL and HDL, triglycerides do not show a strong correlation with CMR and CVD risk. Diabetes mellitus or insulin resistance has no influence on the lipoprotein A values. If LPA is high, we need to use a more aggressive approach to control the cardiometabolic risk. What is the lipid profile? It contains the total cholesterol, HDL cholesterol, NHDL cholesterol, and LDL. Total cholesterol minus HDL is equal to NHDL. NHDL is equal to again LDL plus VLDL. VLDL surrogate is triglyceride by 5, or LDL is equal to total cholesterol minus HDL minus triglyceride by 5. Total cholesterol, HDL and triglyceride only are measured. LDL, VLDL and the NHDL are calculated values. Do we need to have other breakups and ratios? No, absolutely not required. They are totally irrelevant for treatment purposes. Which component of the lipid profile is affected by food? Why fasting lipid profile? Triglycerides increase after food. For the reports to be made comparable to one another, and for the reports to to have proper workup and calculation as above, the estimation of triglycerides correctly is essential. For that reason, we have to order the lipid profile in the fasting state. The above approach of calculating LDL, NHDL and VLDL is what is called Friedewald's equation. Let's say we have the lipid profile of this patient, Mr. Vasudevan. Look at his lipid profile and give the interpretation. What is to be targeted here? I told you only 3 factors are measured: total cholesterol, HDL and triglyceride. The others are calculated values. Total cholesterol is here is 170, HDL is 50, triglyceride 125. So total cholesterol of 170 is very much normal. HDL of 50 is also normal. Non-HDL is equal to 170 minus 50. Total cholesterol minus HDL is 120. Anything up to 130 is normal. That's okay. So the HDL and HDL both are normal. LDL, as far as LDL is concerned, 170 total cholesterol, subtract HDL 50, you get 120, and from that you subtract VLDL. VLDL is nothing but 1/5 of triglyceride. Here 125 is the triglyceride, 1/5 of that is 25. So 120 is the total NHDL, subtract 25 out of that, you get 95, that is the LDL. LDL also is normal. This patient's lipid profile report is normal because his HDL is 50 and normal, his LDL is 95 and again normal, and his NHDL is 120 is also normal. However, we can't just stop short there. We must look for his other cardiometabolic risk factors and risk estimates and try and correct those risk factors. Let's look at this patient, Mrs. Menakshi. What is her lipid profile like? What is to be targeted? Total cholesterol is 170, HDL is 30, triglyceride is 150. TC is very much normal, just as in the previous case, but the HDL for a woman is 30 milligrams is very low. At least it should be 50 or 55 and above. NHDL is equal to total cholesterol minus HDL. 170 minus 30 is equal to 140, should not be more than 130, so it is raised. HDL is low and HDL is high. What is the LDL like? LDL is equal to NHDL minus VLDL. NHDL is 140, VLDL becomes 30 because triglyceride is 150, 1/5 of the triglyceride, 1/5 of 150 is equal to 30, 140 minus 30 is 110, so LDL is also slightly raised. This patient's lipid profile report is abnormal. Her LDL value is slightly raised, 110, HDL value is very low, 30 milligrams, her NHDL 140 is also slightly raised. So we must address her low HDL in addition to taking care of her LDL. Let's see Mr. James's lipid profile. What is to be targeted here? Total cholesterol 270, HDL 50, triglyceride 250. Total cholesterol is very much high. HDL is normal for a man, 50 milligrams. NHDL is equal to 270 minus 50. Total cholesterol minus HDL is equal to 220, way beyond. 130 is the normal, 220. So NHDL is very, very high. How about the LDL? LDL is nothing but the NHDL minus the VLDL. How do we get the VLDL? By dividing triglyceride by 5. Triglyceride is 250 divided by 550, NHDL is 220, 220 minus 50 is equal to 170. LDL is also very, very raised. This patient's lipid profile is abnormal. His HDL though is normal, LDL is very high and HDL is also very high. So he must lower his LDL and treat his NHDL aggressively. Let's see this lipid profile of Mrs. Begum. What is to be targeted here? How to interpret this? Total cholesterol 200, HDL 50, triglyceride is 250. Total cholesterol of 200 is okay, upper normal limit. HDL of 50 for a woman, also upper normal limit, okay. NHDL is equal to total cholesterol 200 minus HDL 50, which is equal to 150, so 150 is higher than 130. NHDL is elevated. How about the LDL? LDL is equal to NHDL of 150 minus triglyceride. How do we get the VLDL? VLDL is 250, triglyceride divided by 5, which is 50. So 150 of the NHDL, subtract 50 VLDL, we get 100, which is again normal. So the NHDL values are raised, but the LDL value is normal. The raise in the NHDL is due to the triglyceride. In this patient, she has got a HDL which is normal, total cholesterol is normal, LDL is normal, but the NHDL for her is elevated, which is abnormal. This is because of the raise in the triglyceride. We must look for her CMR status, particularly diabetes and abdominal obesity, and treat her high triglyceride. Let us look at some of these fascinating facts. Decreasing the LDL by therapy, isn't it enough to reduce the CAD? Can it not wipe out all the CMR or CVD? We have a set of nature's experiments here. The Mazi tribes in Africa, their LDL levels are as low as 30 to 40 milligrams. They do not have any coronary artery disease or atherosclerotic vascular disease. They do not have obesity, abdominal obesity either. CVD is a multifactorial disease including genetic factors. There are two components here, the container, the blood vessel, and the content, the blood. Both are at faulty in a CVD case or in a CMR high risk. The container, the blood vessel, has endothelial dysfunction, atherosclerotic plaques, ruptured plaques, vascular inflammation. The content contains low density lipoproteins, LDL, triglycerides, LDL, intermediate density lipoproteins, and reduced number of high density lipoproteins, and several other glycation end products, inflammatory mediators, procoagulant molecules, several other cardiovascular risk factors in the content. What is the ideal lowest level of LDL? Is it 100? Nay, is it 70? Is it 30? In fact, LDL levels of around 25 to 30 are supposed to be quite adequate for the required steroid metabolism in the body. Probably that is the level at which LDL should stand, but none of us will have LDL of that nature. What are LDL receptors or LDLR? Various arterial trees, arterial beds have different receptor expression and receptor populations. For example, radial arteries, they don't have LDL receptors, they don't have atherosclerosis. Internal mammary arteries, they don't have LDL receptors, they are not prone for atherosclerosis. Coronary vascular tree, fully predominant with LDL receptors. That is the reason coronary atherosclerosis is so common. These LDL receptors are more prominent against stress points on the arteries, at the junctions, at the bifurcations, at the openings of the branches, things like that. What is the LDL level in a newborn? Around 25 to 30 milligrams. In other primates also, if we look at other primates and vertebrates, the LDL levels are very low. That is why those animals do not suffer atherosclerotic vascular diseases. Atherosclerosis, remember, starts very early in childhood, and any corrective measures or risk factor modifications must start right in childhood before the disease starts progressing into a relatively irreversible state. It is the LDL entry into the vascular endothelium, its oxidation, its enzymatic modifications, its glycation, proteoglycation, its aggregation of the LDL particles, and immune complex formation, excitation of macrophages, and all this havoc in the subendothelial layer occurring and producing what is called the atherosclerotic plaque, and once the plaque is vulnerable and ruptures, produces acute coronary events. What are the prevention strategies we have? The eating habits of us should be heart healthy, medical nutrition therapy, decreasing surfers, increasing movers, increasing POFAS, addition of fiber, decreasing carbohydrate, maintaining the overall nutrition in such a way that there is a weight balance and the waist and weight are controlled, increasing physical activity, therapeutic lifestyle change or TLC, and cessation of smoking. All these above methods and strategies will sure reduce the cardiovascular risk and also the lipid burden. But the problem is we never implement them, come what may. Let us have CVD, let us have all forms of atherosclerotic vascular disease, but we will not budge 1 inch, we will not change our habits, we will not apply medical nutrition therapy or increasing physical activity, we will not stop smoking. This is the way the society lives, this is the way our patients are, this is the way the physicians are, either while emphasizing this to the patients or while looking at their own health. A sad story. What are the principles of lipid treatment? LDL lowering is the primary target. Optimal LDL to be 100 in general, if possible lesser than 100. Total lifestyle change or therapeutic lifestyle change with increase in the soluble fiber, decrease in the saturated fatty acids, increase in the MOFAS, increase in the POFAS is the cornerstone of any lipid treatment, lipid management. TLC, medical nutrition therapy plus pharmacotherapy concurrently has to be applied to decrease the CMR as early as possible. Do not wait for the MNT to act, lose time and then start the pharmacotherapy in people who have high risk. Statin in higher doses up to 40 and 80 milligrams may have to be used. Ezetimibe, bile acid resins, niacin are add-on drugs. NHDL is a secondary target and must be met. Once the LDL target is met, we should focus on the NHDL and see that the NHDL target also is met. Otherwise, we will leave a part of the lipid burden unaddressed and unattended to, and that will produce the cardiovascular. What are the strategies of treatment for lipid disorders? Use statins. Use them in the highest dose possible, keeping the side effects to the lowest level. And this dose of statin should keep the LDL as low as possible. If that dose is not tolerated, in order to reduce the dose of statin, combine them with other methods of reducing LDL like ezetimibe or bile acid resins. Statin plus fibrate is a good combination to tackle both the LDL and the HDL and also the triglyceride problem. Beware or be aware of the myositis. No combination of gemfibrozil plus statin please. This produces the worst myopathy. Statin plus omega-3 fatty acids could be a good choice whenever you are targeting an HDL. Statin and niacin on paper appears to be the ideal combination to control all lipid components. But the problem with niacin we know are the side effects profile, the flushing, the pruritus. Niacin when given with aspirin, small dose of aspirin or after meal or when using extended release niacin preparations reduces the side effect profile of niacin. Risk stratification, high risk patients, established patients of CAD, non-coronary atherosclerotic vascular disease like PAD, CKD or stroke or cerebrovascular disease, abdominal aortic aneurysm, symptomatic carotid artery disease, diabetes per se, any two major CV risk factors or a Framingham risk score of more than 20 for 10 years. All these patients are said to have high CMR risk. What are the treatment goals for cardiometabolic risk? Today we can classify patients broadly into those who are at the highest risk, those who are having high risk and those who are having low risk. People at the highest risk means those who have known cardiovascular disease or those who have diabetes plus one or more of the major CV risk factors. And for them these highest risk people, the LDL cholesterol should be less than 30 and the NHDL cholesterol should be less than 100 and the ApoB particles should be less than 80. And the group called the high risk patients means they have no diabetes or known CVD, but have 2 or more additional major CV risk factors, or they have diabetes but no other major CVD risk factor. Diabetes alone classifies the patient into high risk category. For them, the LDL cholesterol should be less than 100, NHDL should be less than 130, and ApoB 100 should be less than 90 milligrams. And then come to the low risk profile patients who do not have diabetes, who do not have cardiovascular disease, who do not have more than one risk factor. The risk factors are 1 or less, and the Framingham risk score for 10 years is less than 10. Such patients, the LDL cholesterol up to 130 is tolerable, NHDL up to 160, and the ApoB levels up to 100. What are the risk factors other than diabetes and dyslipidemia that are being considered? Beyond dyslipoproteinemia, smoking, hypertension, family history of premature coronary artery disease are considered important risk factors apart from diabetes and known CVD. Very rarely we see patients who have isolated increased LDL. Majority of the times, particularly Indians, Asian Indians, diabetics, metabolic syndrome patients, they have mixed hyperlipidemia. They will have raised TG, they will have reduced HDL apart from increased LDLc. In such patients, of course, therapeutic lifestyle change, as we have already discussed, is the sheet anchor of treatment associated with drug therapy concomitantly, not after trying therapeutic lifestyle change. Concomitant use of TLC and drug therapy. The primary target, step 1, is LDLc goal should be met. Depending on the risk stratification that we have seen earlier, the LDLc goal may be 70 or 100 or 130. Usually it is 100 or lower. And step 2 will be, once the LDLc goal is taken care of, non-HDL goal is the secondary target. Increase the statin dose or add another lipid lowering drug like niacin or fibrate, which has got an effect on increasing the HDL and decreasing the triglyceride and thereby reducing the non-HDL level. What are the various mechanisms of actions of statins? It has got 2 aspects: the hepatocyte actions in the liver cell and the systemic circulation action in the plasma. In the liver cell, cholesterol synthesis occurs from acetyl coenzyme A. Acetyl coenzyme A, through a series of steps, is converted into cholesterol in the liver. HMG coenzyme A is an enzyme required for cholesterol synthesis from coenzyme A into cholesterol to incorporate the cholesterol into the cell. These drugs block the action of the HMG coenzyme A and thus reduce the cholesterol synthesis and incorporation of cholesterol into the cell, and they increase the LDL receptor propensity. Once the LDL receptors are increased, LDL that is circulating in the plasma is trapped and then destroyed and degraded into the degraded or sent into the bile. What are the actions in the plasma? In the plasma, the VLDL synthesis is decreased, LDL synthesis is reduced, serum LDL levels come down, serum VLDL remnants come down, serum IDL levels come down, LDL receptor mediated hepatic uptake of LDL and VLDL remnants increases, and these atherogenic particles are excreted through the bile. So, to summarize, reduce hepatic cholesterol synthesis by blocking the enzyme HMG-CoA reductase, lowering intracellular cholesterol, upregulation of the LDL receptors, and increase in the uptake of the non-HDL from the circulation. By these mechanisms, statins reduce the lipid burden. Lowering LDL cholesterol versus the statin dose. How much amount of reduction we can obtain using various doses of atorvastatin or simvastatin. Atorvastatin of 10, 20, 40 and 80. With 10 milligrams of atorvastatin, on the left hand side we see a 38% reduction from the baseline level of 211 milligrams of LDL. And if you increase the dose from 10 to 20, there is another 8% reduction to a totaling of 46%. Then from 20 to 40, if the dose is further increased, there is another increment of 5%. And the last step of increasing it to 80 milligrams has got only 3% more. So, with all these 3 extra titrations, from the first dose of 10 to a last dose of 80, we get a 16% additional reduction. That is all. So to say, a 10 milligram dose of atorvastatin is quite good enough to reduce the LDL cholesterol to around 40%. And if you give 80 milligram dose, at the most you can achieve up to 55%. So we have to decide whether the incremental dose is really worth the reduction that we are going to get. Same is the picture on the right hand side with simvastatin. What are the side effects of statins? We use statins left and right and prescribe to many of our patients. We should be very knowledgeable about the side effect profile of statins. The common side effects are headache, myalgia, fatigue and GI intolerance and flu-like symptoms. They are very mild and do not necessitate stopping the treatment. Increase in liver enzymes occurs. It is a serious problem only in very rare cases. It occurs only in 0.5 to 2.5% of the cases and in a dose dependent manner. The higher the dose of atorvastatin you use, the greater are the chances of liver enzyme derailment. Liver enzyme increase means at least there must be a 4 to 5 fold increase in the liver enzymes, not just 10 units or 20 units. Myopathy, the oft talked about topic of myopathy and statins. One need not fear about myopathy, occurs only in only 0.2 to 0.4% of the patients. Rare cases of rhabdomyolysis. We can reduce this risk by cautiously using statins in people with impaired renal function, in elderly persons, and use the low effective doses and cautiously combining statins with fibrins and avoiding other drugs like ketoconazole, immunosuppressive drugs, azathioprine, anti-cancer drugs along with statins. Muscle toxicity requires the discontinuation of statin. When do we say that the patient has got myopathy? At least there should be a 10 times increase in the CK value, muscle CK value from the upper normal limit. Then only it is myopathy due to statins, otherwise it is not. What are the various pharmacological options we have? If we are treating a patient who has got high LDLc and our primary target is LDLc, these drugs like statins, ezetimibe and bile acid sequestrant resins lower the LDLc more than the triglyceride. There is another group of drugs which lower the triglyceride more than the LDLc. They are the niacin, fibrates and omega-3 fatty acid thylesters. So, the primary target of LDLc is taken care of by statins or a combination of statin and ezetimibe, in some cases a combination of statin plus bar. If the secondary target of NHDL has to be addressed and the triglycerides have to be lowered, either we have to choose a combination of statin and niacin or statin and fibrate or statin and omega fatty acid. How does fenofibrate act? The mode of action is, it is a PPAR alpha agonist, peroxisome proliferator activator enzyme. It is a nuclear enzyme and the alpha type of that enzyme, PPAR alpha agonist. These enhance the activity of lipoprotein lipase, reduce the hepatic fatty acid synthesis, inhibit the HMG-CoA reductase activity, reduce the CETP activity, increase the LCAT activity, increase the production of ApoA1 and ApoA2. In nutshell, fenofibrate acts in all the areas of lipid metabolism and transport in the liver as well as in the plasma. We have seen in the previous slide a combination of statin plus niacin. Here we are seeing the slide on statin plus fibrate, simvastatin plus fenofibrate, pravastatin plus gemfibrozil. Simvastatin plus fenofibrate on the left side, on the right side gemfibrozil and pravastatin. You can see in both the groups the LDL reduction is marked, HDL is increased and the triglyceride is reduced. The combination of gemfibrozil and pravastatin appears to reduce the triglyceride much higher than the fenofibrate combination. But gemfibrozil has got myotoxicity. When you combine with statins, the myotoxicity is more with gemfibrozil or clofebrate. So it is better to combine fenofibrate and simvastatin rather than use gemfibrozil. Now once we set our target on the LDL, then the next important thing is to bring up the HDL. How to manage the low HDL? Less than 45 milligrams of HDL is a low value. Majority of the Indians, majority of the women, around 95% of the women and around 86% of the men have low HDL. Targets of therapy: achieve the LDL goal first. For treating the HDLc, first you get the LDL goal. Waist and weight reduction in patients with metabolic syndrome increases the HDL. NHDL goal should be achieved. Consider niacin or fibrate. Niacin is a better drug to increase the HDL. Increase the physical activity and then smoking cessation. These together with the above measures will address the low HDL. This chart represents the unique contribution of HDL as a coronary risk factor. Look at the people who have LDLc of 100, the most left hand side bars. With decreasing levels of HDLc, the risk is increasing even when their LDL cholesterol is 100. And take the group of people whose LDL cholesterol is 160. Even in them, a further reduction in the HDLc from 85 to 25 is increasing the CHD risk rate. In those people who have LDLc of 220 but who have got HDLc of 85, the risk is very small, as much as people who have LDL of 100. So this demonstrates the protective effect of LDL cholesterol beyond. What causes low HDL? Smoking, visceral obesity, visceral fat, physical inactivity, high carbohydrate diet, type 2 diabetes, hypertriglyceridemia, drugs like beta blockers, androgenic steroids, progestins. These are some of the causes of low HDL. Of course, the genetic makeup. The Indians in general or phenotype B have more of atherogenic lipoproteins and less of atheroprotective apoprotein A. So that in turn reduces the LDL. Once we have addressed the LDL cholesterol as the primary target, our next step would be to target the NHDL and to improve the HDL. The best combination probably as on date appears to be statin plus niacin. As you can see, this combination here, either simvastatin plus niacin on the left hand side or fluvastatin plus niacin on the right hand side, both these combinations are reducing the LDL significantly, increasing the HDL also significantly, and reducing the triglycerides significantly. So this combination of statin plus niacin, of course the same thing holds good to a combination of atorvastatin and niacin, and atorvastatin is a more potent drug than fluvastatin or simvastatin in reducing LDLc. The HDL component is increased automatically by niacin, and triglyceride is reduced by the niacin as well as by the statin. So the combination works to the greatest advantage in reducing the atherogenic. This is another slide to show you the effect of combination of statin with niacin. Here lovastatin 20, 40 and lovastatin 20 plus niacin 1000 are used. The red bar is the lovastatin 20, the green bar is lovastatin 40, and the gold color bar is a combination of lovastatin with niacin. You see, any of these three groups, they have the LDL cholesterol reduction is same, but when it comes to the HDL, the combination of lovastatin with niacin is the one which has got the profound effect. And when it comes to the reduction of triglyceride, again the combination of statin and niacin is doing the job well. With this we know that statins of course can reduce the LDL cholesterol to a very considerable extent, but they are not good drugs in order to keep the triglycerides down and to increase the HDL. When you add a combination of niacin to the statin, these non-LDL atherogenic particles are taken care of and the NHDL burden is reduced, and the total atherogenic component of the plasma is taken care of. Does this combination of statin and niacin reduce the atheroma burden as measured by carotid intima media thickness or CIMT? The bars on the left hand side are the baseline values. The red one is statin and placebo, the gold one is statin plus extended release niacin. On the right hand side we have the red bar statin plus placebo. There is a reduction in the CIMT after 1 year, but if you see the statin plus niacin, the reduction is profound compared to what occurred with statin alone. Statin alone can reduce the CIMT burden, CIMT values and the atheroma burden, but if you add niacin, the CIMT values are much lower and the atheroma burden is reduced. We have seen how to optimize the statins, what are the dose differences, how to combine statins with other lipid lowering drugs like niacin and fibrate to get the HDL cholesterol on target. We have discussed about the role of NHDL and how to calculate NHDL and the LDL subfractions using a lipid profile. Now we see a little bit about what are the actions of statins beyond lipid lowering. Statins increase the endothelial nitric oxide production and improve the endothelial dysfunction. They regress the atheroma and the plaque burden. We have already seen the 2 slides on the CIMT. They increase the expression of the tissue plasminogen activator 1, which is atheroprotective. They decrease the expression of endothelin 1, which is a very potent, notorious vasoconstrictor. They stabilize the plaque via lipids, via the macrophages, via the matrix metalloproteases. Statins reduce oxidative stress, which is independent of the cholesterol lowering activity. Statins decrease the inflammatory markers like hsCRP, tumor necrosis factor alpha, interleukin 6. Statins are anti-inflammatory at the site of the plaque and thus stabilize the plaque. Statins inhibit platelet aggregation and they have also got antithrombotic action. All these actions occur before the actual lowering of the cholesterol occurs. So these are the summary actions of statins beyond lipid lowering. Are statins safe? Excellent patient acceptance, few drug to drug interactions, fewer side effects. Most common, as we have seen, are GI and mild to moderate. At high doses, elevated enzymes can occur in 1 to 2%. Myopathy in a small proportion of cases. CK more than 10 times the upper normal limit, only we will call it as myopathy. Rare cases of toxicity warranting the treatment to be withdrawn. There is no increase in total or non-coronary artery disease related mortality associated with statins. These are some of the conclusions of the Statin Advisory Committee. Statins reduce the incidence of major actual coronary events. They reduce the number of procedures done on in the coronary arteries like the PTCA or the CABG. They reduce the incidence of stroke and amputations due to PAD. The potential of statins is not fully realized. We physicians underuse the statins either in prescribing the statin or in prescribing the right dose. Underused, underdosed in many a practice. Statins are very safe in a vast majority of patients. There is the strongest evidence base for statins. Innumerable number of studies, more than 200 randomized controlled trials have proved that statins reduce the CMR and reduce the CVD. In selected patient groups, caution is needed while using statins. To summarize, this is some of the key points related to lipid treatment. Statins reduce all forms of CVD events by at least a third. This is true both for primary and for secondary prevention trials. Evidence for statins is clear-cut as far as their wonderful morbidity and mortality reducing role is concerned, but this is not the case with fibrates. What should be the target value of LDL and NHDL? Every day it goes on declining. The lower the better is today's guideline. ApoB levels are more effective targets for decreasing the CVD. If you estimate the ApoB to ApoA1 ratio, that best summarizes as an index of cardiovascular health or CVH. CVD or diabetes by themselves are absolute indications for statins, any form of CVD or diabetes. Statins are the mainstay of treatment for lipid lowering, but let us remember that we need to be aggressive to achieve the full benefit and potential of statins. Intensive LDL lowering must be the objective of every treatment plan, of course within the framework of minimal toxicity. What are the newer methods, the newer drugs of approaching the lipid problems? In order to reduce the flushing of niacin, it is being combined with another molecule, another chemical, which prevents the prostaglandin pathways, and then which arrests the accumulation of excess prostaglandins which cause the flushing, and this molecule is called laropiprant. Laropiprant, when it is added to niacin, it is supposed to reduce the flushing. It is still under investigation. The CETP inhibitors, cholesterol ester transfer protein inhibitors, popularly known drug torcetrapib of the Pfizer, has been tried and then promised a lot to increase the HDL, but the trial showed that there was more harm with this drug than what is expected. It is supposed to reduce the CV mortality, and on the other hand there were adverse effects more with this torcetrapib. So much so this trial has been withdrawn. There are other newer drugs which are being developed to inhibit the same enzyme CETP, and they had to be given the full license, and they are still underway. The newer methodology of tackling the LDL problem is by increasing the LDL receptor expression by modifying the mRNA of the LDL receptors and inducing the mRNA of the LDL receptors using the drug called mavinoline. The other group of drugs are squalene synthase inhibitors, which are better than HMG-CoA reductase inhibitors. Hydroxymethyl gluteryl CoA coenzyme inhibitor is what is the statin, and which is supposed to be the wonder drug of the past 2 decades, and then this particular drug is, we know, has got some problem with myopathy, and the squalene synthase inhibitors are supposed to overcome this problem. There is another group of drug called the ACAT inhibitor. This is acetyl coenzyme A cholesterol acyl transferase inhibitor, Avasimi. This also promised a lot, but again ran into some problems. Newer drugs of ACAT inhibitors are being developed. The other group of drugs are the dual PPAR agonists, those drugs which act on PPAR gamma as well as PPAR alpha. We know that PPAR alpha and PPAR gamma have different actions on the lipid front and on the glycemic front. Ragaglitazar is a drug which is being developed, which is supposed to have a dual PPAR action. So these are some of the newer drugs as far as lipid story is concerned. My dear friends, let me conclude by saying that we all now have an opportunity, an unparalleled opportunity to prevent atherosclerotic vascular disease. But this is possible only if we all act to identify people at high risk of cardiometabolic disease and prevent the risk factors and the development of frank CVD and the mortality and morbidity associated with it. With these words, I conclude this talk. Thank you very much.